Chapter 6. Chapter 6 is communication and teamwork, probably one of the most critical and crucial skills that we have in EMS. A lot of the other skills, such as assessment, I mean, yes, it's extremely important. However, if we're not able to communicate during assessment, it really leaves a lot to be assumed. And, of course, teamwork is critical because we don't do this job by ourselves. Sometimes you may be the first person to get there, but generally there's other people coming to assist you. And, I like to joke around that why do they call them paramedics? Because they come in pairs. Well, that's maybe not so far off. Not technically the reason why they call it, but, EMS does tend to respond in groups. So, and we don't do it alone, just the ambulance. So a reminder that just viewing the lecture, the recorded lecture, is not a replacement for your reading and studying the textbook. So our education standard, the AEMT applies fundamental knowledge of the EMS system, safety and well-being of the AEMT, the medical, legal, and ethical issues to the provision of emergency care. I also remind you that this is the last chapter in the second section here that we're covering in this course. Technically the first section of the textbook, however, with us covering the skills first, will be the end of the information on exam number 2. I have a couple of multimedia videos that you can take advantage of from the non-recorded PowerPoints, and some of those are very good. The Understanding Cultural Perspectives video, because we are in such a multicultural society these days, we oftentimes will become what's referred to as ethnocentric, where we really look at our way of living is the only way of living. And obviously that's not true. There's many, many ways of doing it. Objectives. Of course, I'm not going to read the objectives to you. You're more than capable of doing that. And there are a lot of them for this chapter. About 2.5 pages worth of them, which you will find on pages 109 through 111 in your textbook. We will skip ahead of those. I told you there was a lot of them. All right, so for our introduction, it is not possible for us to perform our role without communication and teamwork. If we cannot work with somebody else, if we cannot communicate with somebody else, number one, we're never going to be able to get any information on our patients. Secondly, we're not going to be able to pass that information on to anyone else. So communication is required in every phase of our call, whether we're communicating with a dispatcher, with our fellow EMS providers, if we're communicating with hospital and allied health personnel. It's there everywhere, even after the fact when we're writing it down. That's a form of communication when we're writing it. So, and then that teamwork, of course. Without the teamwork, we don't achieve high-quality patient care. If we have to do it all alone, imagine you yourself going on an ambulance call for a extremely ill or injured patient. We'll say a cardiac arrest. Imagine trying to work a cardiac arrest if you were the only one that could do anything besides, standard muscle work, lifting and moving. If you had other people that were able to do that, but they were not medically trained, they weren't able to bag the patient for you, or push on the chest, or put in an airway, or start an IV, or and so on and so forth. Without other people along the line, it becomes very cumbersome. Even in a standard patient care setting, we'll say an unresponsive diabetic patient, if we don't have partners to help us out, it starts to become a long, drawn-out process, and the patient needs their sugar immediately, but we have this hypoglycemic patient that we have to, start out doing an assessment on. We have to drag in the equipment, do the assessment, take the vital signs, do the hands-on, get the history for where we can, maybe have to snoop around the house and get a few bits of information and details there. We have to then check the blood sugar, and after we check the blood sugar, set up the IV, start the IV, make sure the IV is running okay, grab the drug, the D50, put the D50 together, get the D50 administered, And then start our reassessments where we're rechecking the patient. We're getting more details now because the patient's waking up. Maybe we're rechecking the blood sugar. We're loading them up on the cot. We're rechecking the oxygen. We're rechecking the IV. And it go on and go on and go on. We can just say, if we had to do it all by ourselves, it would not be an efficient process at all. When you have good partners, when you have good teamwork on your service, everything moves that much smoother and that much quicker. I've had partners in which I didn't have to say a word. They really knew where I was going. Unless something weird or it was something kind of out of the ordinary, I didn't have to tell them, okay, get a set of vitals. Okay, get them on some oxygen. Okay, let's set up an IV. Let's put them on a cardiac monitor. With the exception of a few paramedic level items from time to time that maybe my partner didn't know what drug I wanted. There was very little that had to be really said. So teamwork and communication do not always come naturally. It would be great if they did, but interestingly enough, a lot of people in EMS are not particularly people person either. So they struggle with this a little bit. They struggle with communication. And we have to be aware of the principles of the communication process. I think we've all probably been in, we'll move ourselves outside of the EMS world. We've probably all been in a relationship at one time or another in which it just didn't work. Everything was great. Maybe there was, sparks there, and interests were similar. But when it came down to an issue in the relationship, you guys just couldn't talk to each other. Just couldn't figure it out. And it probably was just a matter of miscommunication, a matter of mismatch of communication styles. There are obviously the introverts amongst us, the extroverts. Some people are a little more people-person-y, outgoing, exuberant. Some of us are a little more reserved. There are those of you who think, I got a night off, we're going out, and there are other people like, I got a night off, I'm staying in. So, it's a matter of personalities and how personalities may be able to work together. And you got to know what the communication process is. So I think a lot of times there's a lot of assumptions made in the communication process where, people might have a facial expression that is more of an expression of concentration, and other people may read it to be a facial expression of condemnation or, I'm mad at you, I'm furious with you, simply because they kind of have a little bit of a furrowed brow or a raised brow and say, one person is actually concentrating and the other person takes this, wow, well, they're pissed off at me. So that in and of itself is a miscommunication. We also have to understand the use of specialized EMS communication equipment. And this changes from time to time. It's a different era now. Nearly 25 years into my career, things have greatly changed. The radio frequencies and the radio systems that we're using these days is much different than it was just over 2 decades ago. All right, let's think about it. It goes with your case study in the text. All right, so communication is the exchange of messages between the sender and the receiver. And there's a lot of different things that can affect this. It can be the environment, the sender, the message, the receiver, the channel, the medium. Lots of different things that have the potential to go wrong here. So if we have something such as a noisy environment, if we have a noisy environment, does it change the message that somebody may get? Because somebody may be now shouting or yelling, does that change the perspective that somebody may get from that? I like to bring up this example a lot. Is we really must invent a sarcasm font for text messaging, because a lot of times when we're doing text messaging, we may be intending to be funny, but it's not taken as funny. It's taken as, oh, well, what did you mean by that? Almost a personal attack. So we have to consider some of those things that when we change the medium or the channel, we maybe are changing the message a little bit. The receiver and the sender usually need to be similar we'll say education-wise, but when I say education, this may also be things like, street cred, street smarts, common sense, of the same, stature when it comes to communication skills, I guess, because somebody may be talking at a very high level, and the receiver is unable to really understand that. And sometimes people would feel like, well, I'm ashamed that I don't know what this means, and I'm embarrassed. So, I'm just going to nod my head and say, yeah, I know, I understand. And in those cases, there is a miscommunication. And in the cases of a patient care aspect, there may be dire consequences of that. So, characteristics of our sender: establish credibility, expertise, and trustworthiness. Why do most people introduce themselves, say in the beginning of a course? They probably tell a little bit about themselves, kind of pass along their education, their background, so on and so forth, their credentials. Why do people tend to be a little more dressed up than their audience? Well, that helps to establish that credibility, that expertise, and trustworthiness. Somebody just popped up in front of you and said, well, I don't have no schooling and I don't have no licenses, but I'm going to tell you about heart surgery, and they're in bib overalls. I think people could probably have a difficult time following that person. They don't have a rapport. They don't have a mental relationship with that person. They have a very difficult time connecting. The sender needs to be easy to talk to. They need to be able to convey some empathy and some respect. So they need to be able to understand and ensure that they have the correct tone. They're setting the tone. And when I say tone, I don't mean that specifically in a phonetic or in the sense of sound. I mean setting the environment. So standing there with your arms crossed and your brow furrowed, even though you may be completely intent and completely empathetic with what's being discussed, it doesn't convey that message. Senders also must keep an open mind, and what you may be saying, well, why does the sender have to do this? Because remember, a sender is eventually going to become the receiver. So this really is on both sides of the equation. So the sender and the receiver, because they're going to switch places throughout the conversation. So keep your open mind. Do not make judgments. Do not interfere that will interfere with the ability to listen, and try to understand the message being sent. If you are trying to come up with a response, you are not actively listening to the message being sent. If you are already calculating what you're going to say next, oh boy, that just made me mad. Here's what I'm going to say to that when she shuts her mouth. That is, you've already lost part of the message because you didn't get it. You didn't hear what was being sent. Your mind was preoccupied elsewhere. And senders need to be able to maintain their composure. This can be very difficult for us to do when we are in a situation with an angry patient or with angry family members. So you have to set the tone. You have to kind of set the environment. If you are the EMT, you are expected to be the one of authority. You are expected to be the one who is there to handle this crisis and who is able to make the patient feel comfortable with you, make the patient believe in your abilities. So a lot of times even simple things like your appearance. Appearance says a lot. It may not tell the whole story, and that old adage says, don't judge a book by its cover. That's easier said than done. A lot of times our first impression is of what we see in a person. So I really want to strongly suggest that you keep in mind your appearance when you're responding to calls. So receivers. The receiver characteristics include things like their personality, their intelligence, their self-esteem, their language, stress, and they need to use active listening techniques. Now, I kind of alluded to this on the last slide when I said if you're calculating your rebuttal, you are not actively listening. So the receiver has to have the ability to decode this message. And so that includes things such as their intelligence, their personality. So if they're a very cut and dry personality, they're a very staunch and stern person, they may not be able to get some of the sarcasm. I like to, I'm a huge fan of the Big Bang Theory, and knowing that if anybody watches Big Bang Theory, you'll know that Dr. Sheldon Cooper on there, who is an incredibly intelligent person, has absolutely no common sense and doesn't understand sarcasm. So that type of person as a receiver can be very difficult to have a communication with if you're on kind of a lighter note, because they don't get it. Self-esteem, intelligence, obviously if you're not on a similar intelligence level. Don't take this wrong, but I want you to think about your education versus the education of most of your patients. Now, we're not saying that your patient is stupid. We're saying that your patient is ignorant in some manners. So if we go in there talking about, well, have you ever had an acute myocardial infarction? What sort of ejection fraction do you have coming from your heart? Now I see you have congestive heart failure. Do you take any cardiac glycosides? And I mean, we can start going on and on and on and rattling off the jargon and whatnot. The patient doesn't understand that. And again, the patient may not want to look dumb, so they may just answer the question with a yay or a nay, and we didn't really truly get the answer to what we were looking for, but they just didn't want to look stupid. So and that kind of plays into language as well. Do they speak the same language? Healthcare people, actually any profession is defined by its lingo and its jargon, so essentially its own language defines a profession. So if we're talking all of our medical lingo jargon, we all understand it amongst ourselves usually, but once we start employing lay people and we're talking with patients and family members, they may not get it. And even in the EMS sector, we even have our own jargon that other people don't understand. So when we start talking about blood pressures by palpation, other medical professionals do not do blood pressure by palpation. They don't have any idea what that is. So instead of saying, well, we got a blood pressure of 120 by palp, tell them we have a systolic blood pressure of 120. They get that. They don't get palpation. They don't get traction splint. They don't get KED. They don't understand what a type 1 ambulance is. So we have our own subset of jargon that we use in our profession, and even other medical professionals, physician medical directors and nurses that we deal with in the emergency room, they may not fully understand. Nobody else uses mask pants. We're the only ones. So nobody else is trained in the use of a backboard right out of school. It requires them to go take additional training and trauma classes to learn about those things. So there's a lot of things that we have as a distinct advantage when it comes to knowledge-wise over some of our compatriots. Okay, and the exchange needs to be in a way that both parties understand. Again, keep the medical jargon out. So if we're talking with patients, leave that crap out of there because they don't understand. One thing that's changed really since 9/11 is the way we talk on the radio. We don't use 10 codes hardly ever anymore. I mean, 10-4 is kind of universal and everybody understands that one. But beyond that, most places 10 codes are a no-no. And it's because they're not always the same. Nebraska and Iowa, for example. In Nebraska, the old 1045, the term 1045, was a personal injury accident. So somebody was hurt in a car crash. In Iowa, it was a 1050 PI, personal injury, as opposed to a PD, property damage. 1044 in Nebraska was a property damage accident. There was one 10 code that was something that we used on a regular basis in Nebraska, but in Iowa, it might have been 1045. In Iowa, 1045 was an animal carcass in the road. Well, that's similar, but not really the same. So even that close, the Missouri River, there was completely different language on the radio than there was on the other side of it. So you could take Carter Lake, for example. Carter Lake, Iowa, which technically is an enclave into Nebraska. It's on the west side of the Missouri River, technically the state of Iowa. You know, it's connected by land to Omaha, but nonetheless, it had a different language. So some channels, verbal versus nonverbal. Verbal obviously is the spoken channel, whereas nonverbal is other methods of communication that include things like body language, written, so it would be a written documentation, it might be notes. It could also be things like texting or the things that we may get on a pager. So verbal obviously is spoken. And then interference. Can we have interference? Can we have issues? And I think we've probably all dealt with this. If we've been around the block a time or two in the EMS world, we've had interference. We can't hear what was going on over the pager. We were just far enough out of range that we kind of got static over the pager or over the radio. Maybe there is a lot of loud noise in the background. The patient might have a hearing aid that's not working. We have sloppy handwriting. That's me. I think you guys will rarely see me write much in class for the simple fact that my handwriting is terrible. I do not use cursive for anything but my signature, and that's because it is so bad and so sloppy, it's just terrible. When I do print something by hand, it is in all caps. I type in caps. I write screaming because everything's caps lock, but it's just cleaner for me to do that. When we go back to hearing aids, remember there's a lot of people who don't have hearing aids who could benefit from one. So one of the things that I've made a kind of a practice is if I walk into a scene and there's all kinds of distracting noise and background, I'm kicking people out saying, hey, we don't need you in here, go on, telling people to turn their walkie-talkies down, turn them off, squelch their pagers, whatever, and reach over, turn off the patient's scanner, turn off their TV or their stereo or their radio or whatever. Get rid of as much of that background interference that we can. So there are all kinds of issues. Sometimes we have radio systems and cell systems going down. So we may also have things such as poor poor vision. If we have poor vision, the patient may not be able to see if we're pointing at something, or the patient may not be able to fully identify something that we're trying to get them to look at or tell us about or show us to. We may have poor diction. Maybe the people just are not well educated, and so they can't really give us everything that we need. So it's sad, but we still have a large disparity between people throughout the United States where we don't have a standard level of education. I mean, we try, but there's still a very widespread. We may have also intruding thoughts and fears, and maybe some environmental noise that's in there. So we may have dogs running around barking, so get those out of there. Intruding thoughts, people are going to be concerned. You show up at an older person's house who's fallen, I guarantee you this thought has crossed their mind. They're over the age of 65 and they're starting to become elderly. This thought has crossed their mind. What if I don't come back home? Nobody wants to go into a nursing home and never return to their home. So that is almost a guarantee that they've thought that or they've felt that. Maybe they're extra upset about the situation. They're not able to communicate clearly. We may have cultural differences and language barriers. Remember, in some places, and I think most people who come to the United States quickly learn some of our cultural aspects. But there are some places that extending your hand to shake somebody's hand could be seen as a sign of disrespect. A lot of Asian cultures, you don't look people straight in the eye. That's a sign of disrespect. So language barriers. This is huge. It's huge, and it's not getting better. Obviously, Spanish is huge throughout Iowa and Nebraska as being a another language that is used a lot, but there are others. There are people who speak strictly German. There are people who speak various African dialects. So there's a lot of different languages that we can bump into and run into here, and it can make things very difficult. All right, so there's a link actually to a cultural perspective video. Feedback. Feedback is information about a system's output that is returned to its source to modify further output. What the heck does that mean? Basically, that's saying, okay, I'm getting what you're saying, or no, I don't understand what you're saying. That's in very simple terms. Yes or no, I'm getting this, or I need more clarity. So that's what feedback is. That feedback is helping to pin down the exact points, or admitting understanding of those points. So try to be specific to minimize misunderstanding. If we want to know specific information, we kind of close the gap on it. We maybe give them just a couple of choices to pick from. We may ask them very specifically, have you ever had a heart attack? As opposed to, have you ever had heart problems? Do you have any history of heart issues? We want to know specifically, have you had a heart attack? Then we do this very closed loop question and say yes or no. It's a yes or no question. Whereas we can leave things wide open. Explain to me what your discomfort feels like. It's sharp, it's stabbing, it's burning, it's pressure, and so on and so forth. So by leaving it wide open, we may have to then stick a feedback loop in there and say, okay, you said it's kind of a pressure. Is it a pressure like a band around your chest? Is it pressure like something pushing down on your sternum? Give me more information. All right, so our AEMTs communicate by radio many times, cell phones, text devices, pagers. We may have computers and other written reports. A lot of times we're also speaking directly with another person. So there are many different ways we do that. Body language a lot of times. Sometimes we're kind of using signals. Sometimes we still talk in a little bit of code because we don't want people to fully understand what we're saying, what we're doing. Say, for example, maybe you as a student are going out to do some internship time and you forgot to put oxygen on your patient, and your preceptor might kind of put his fingers up to his nose, kind of like put in a nasal cannula, or maybe he puts a hand around his arm and kind of squeezes, get a blood pressure. We can use those things, and it can be less concerning to others if they don't quite understand it, but we're able to pick up on the drift of things. If you don't fully understand what they're shooting for, or you're in question, of course you need to clarify. So a team is a group of individuals with specific common goals, and in EMS, not only pre-hospital but emergency department and first responders, we all have that same common goal: get the patient the care that they need and get them started on the road to recovery. All right, so we tend to form teams to provide prompt, safe, efficient, high-quality patient care. You got to know what your role is. So sometimes it's, if you're working with the same level provider, you have to switch off. So this call I'm driving and you're attending, and next call I'm attending and you're driving. So knowing what the goal is. Maybe sometimes you're responding to a call with 3 or 4 people in your truck, and the team leader, captain, whatever you want to call them, might start to say, okay, Bill, you're going to take airway. Jim, you're going to take vital signs. And Nancy, you're going to do the physical hands-on assessment. So you can coordinate those. And that requires communication as well. Maybe somebody's doing something. Maybe whoever was assigned to take care of the airway, they get there, the patient's alert, oriented, they're talking, their SATs are like 99%, they have no evidence of shortness of breath. You may need to reroute that person. You may need to give them a new assignment, or they may need a different role. Maybe we need something else. Maybe we need an IV set up. So effective communications are essential to your safety and your patient's outcome. If we don't effectively communicate, things can go horribly wrong very quickly. You may say, give me the epinephrine, and they may hand you epinephrine 1 to 10,000, which is not the concentration you should be giving your patients. You should be giving 1 to 1,000. But they handed it to you, you didn't pay attention, you just plain gave it, and wham, now you have somebody that's incredibly ill. Team communication, they can break down. Sometimes somebody just came to work and they're mad, and they don't like you because you left the truck a mess the last time. There's that barrier already before we even get to patient care. So those interpersonal relationships may not always be as good as possible. Maybe there's something outside of your role in EMS. You beat somebody for a spot on the school board, or your team beat my team in softball, so now I'm mad at you, or you're a Green Bay Packers fan and I hate you. So stupid, but it interferes. So, and how can you contribute toward better teamwork? You don't have to love everybody, you don't have to like everybody, you don't have to hang out with everybody, but you do have to work with those other people. So you have to try to make an effort to establish some sort of a working rapport with them. All right, so with our rapidly evolving technology, we have an agency that oversees much of communications for EMS, public safety. Actually, they control a lot of communication. It's the FCC, Federal Communications Commission. They approve the equipment standards, they assign broadcast frequencies, they license base stations, they assign radio call signs, and they will issue and enforce regulation. So, for example, in Iowa, I believe 155.340 is the primary EMS frequency that at least has been for many, many moons. There are other frequencies that sometimes get used. You might have a different frequency for paging, but we maybe have to switch from frequency to frequency and make sure that we have our radios on the right channels so we can be communicating. With base stations, that's usually who actually holds the license for us to be using. So it might be our hospital, maybe it's our fire station, whatever, or it may be the comm center for the county. And then radio call signs. They don't get used as much anymore as they used to, and a lot of times they're now put into a Morse code. But so those radio call signs get used to identify the specific radio station. The FCC also talks about who should be using what on what frequencies, and they do go out and they do spot check and they do listen to see if people are obeying the rules. So the FCC's got a huge responsibility. Okay, so backup systems, having maintenance. We often forget about the radios. I mean, we take good care of putting away all of our other equipment, making sure that the cot is lubed and nuts and bolts are tight and whatnot, but we often kind of forget about our radios, and we're hard on our radios, particularly if there's one you're carrying on your hip, whether it's a pager or whatnot. We're hard on them. I think there's probably providers every day easily that are breaking their radio, breaking their pager, breaking their cell phone. We do this because we're just hard on stuff. So making sure that we have proper maintenance. We're checking to make sure our communication equipment works. And it works between multiple agencies. So this is interagency interoperability between the agencies. So being able to talk to the people in the town next door. So if we're transporting to a hospital, do we have their frequency? Do we know how to get a hold of them? We have to have that. We have to work on that. We have to look at our systems. What is the probability that we may ever go work with towns B, C, and D? And if that's a possibility, do we need to develop some sort of an agreement? Do we need to enter their frequency into our system? Maybe it's something on a county level. The county needs to come together and say, okay, we have all these departments. They're all running off of different frequencies, but they're very similar frequencies. Let's develop a standard frequency that everybody can use in cases of mass casualty, mutual aid, so on and so forth. And the state of Iowa, I know, used to at least have a frequency that they referred to as mutual aid. And the mutual aid frequency, everybody in a specific area would plug this mutual aid frequency into their radios, and in that large-scale disaster, everybody would switch to it. So EMS radio systems, they operate on assigned frequencies or channels. This is going to vary from state to state. Nebraska uses a kind of a different radio system. They've been migrating their radio system to a little better frequency range in recent years. But even with that being said, we talk areas like metro areas. The big cities, they may be operating on like an 800 or 900 megahertz band, where the smaller towns, the smaller systems may still be operating off of the 400 band or the 100s band. So the assignment of frequencies usually is in conjunction with some of the established rules. We may have public and or private radio frequencies. So remember that private agencies also are going to operate off of radio. They may have their very own. Digital. Digital is the big push. Go into digital communication. The better quality signal. But it also requires you to change equipment. So I hear from people from time to time who forgot that a couple of years ago they changed, the FCC changed the over-the-air transmission signal of most standard TV stations. So your standard ABCs, NBCs, CBSs, when those were being broadcast over the air, it used to be you had this set of bunny ears, and that's how you received your TV channels. Then everybody kind of moved to the cable thing and or satellite, and kind of forgot about their local channels. Well, some people decided they wanted to just have over-the-air channels again, and that has changed. That standard has changed. That signal is now digital, and your standard old rabbit ears doesn't work anymore. You have to have a different type of rabbit ears, a different type of converter to accommodate digital. Push-to-talk systems, depending on whether you're using mobile phones with that technology, but most radio systems, you have to press the button to open the channel and start to transmit. So that's that button on the side of the microphone or that button on the side of your walkie-talkie portable radio that you have to press in order to get your message to be transmitted. So a lot of times we'll use the term traffic. Traffic is the back and forth of the radio communication. So people talking, people receiving, and clarifying. Sometimes codes and signals get used, but again, they're not a very reliable system, particularly when we're talking interoperability. So some places will have a specialized 10 code that they may use just in-house. So take, for example, a service I'm familiar with uses a code 1052, and I don't even know what that means in the state that they are in, but their version of 1052 means we're going to get lunch. So sounds better than we're going down to Bob's Big Burger to get some lunch. We're going to be around a certain area for 1052. Sounds a little bit more professional. So using that language back and forth. Preferably, if you don't know specifically some terminology, use plain language. And that counts for radio communication as much as it does for interpersonal face-to-face communication. If you just don't understand, use plain language. It's okay to say things such as message received or affirmative or 10-4, like I said. That's kind of universal. A lot of people do use that, but most of them have really fallen out of favor right now. So documenting times. Times, we have a number of things that we need. Number one, times are a legal record. So that legal record is something, if that ever gets called into court, they're going to look at that. Additionally, they're going to look at things as times for quality improvement. They're going to look and see, were you on were you functioning at your capacity? Were you functioning within protocol? And then they may use that scientifically to say, well, we noticed that if we got defibrillation in within 90 seconds, that it did so much better than if we only, we waited 5 minutes. Patients had a much better outcome if they had immediate. Now, we know that now, but is that something that we've always known, or is that something we really relied on the times in order to feed us that information so we can guide our practice that way? All right, so here's an example of actually a dispatch center base station radio. There's obviously numbers of computers and maps and whatnot going on here. You can see in front of this female dispatcher here, there's a set of flip charts with kind of a green cover, yellow writing on it. That's a set of EMD cards. So they'll get a common complaint, they'll flip that card, and they'll start going down that protocol or down that decision tree to kind of guide the patient and make the appropriate dispatches. So the different types of communication equipment we run into: base stations, mobiles, portables, repeaters, digitals, and cellular, telephone, or mobile phone. So we've got a large number of items that we're using these days, and things have changed over time. I remember some of the older radios that I used to use were enormous. They were bigger than a shoebox was the true radio itself, and today they've gotten to become so small that they're about the size of a sandwich. So there's not a lot. Technology's helped out a lot there. Base stations used to be almost as big as like an oven. They were huge boxes that had to be placed somewhere in order to receive and send these messages, and they were higher powered. Base stations typically are 100 plus watts, maybe even more. So they cover a large area. They may cover several counties. Mobile radios, these are the ones that are mounted in your trucks, so your ambulance or your first response truck. You have a mobile radio that's probably around 50 watts, and you will cover roughly a county. In most counties, I guess if we go and talk Kasuth County, or even Pot County for that matter, both of those are fairly large counties. You may have a little bit more difficulty covering those. We'll take Cherry County, Nebraska. There's no way it would cover it. Cherry County, Nebraska is larger than the two smallest states put together. So there's no way you're going to cover that with a mobile by itself. Portables are the ones that people wear on their hips. These are usually around 2 to 5 watts. You might be lucky to get across town on your portable radio. Of course, a lot depends on who you're talking to. Portable to portable would be more difficult across town, whereas portable to base, you've got better power, better receiving, better transmitting. Repeaters are systems of basically base stations that are strategically placed throughout a geographic area to boost a signal, to receive a signal, boost it up, and retransmit it. It at least used to be possible, and I think it probably still is, that with the repeater system that the State Patrol has in Iowa, that they could activate all the repeaters. Somebody flips a lot of switches and does a lot of settings or whatever, and people on one end of the state could talk to people on the other end of the state off of their portable radios. You may have repeaters that are built into vehicles, so mobile repeater systems. I've worked with those. The common characteristic you'll hear of somebody using a repeater is there's a little squeal or a little tone that will kind of bleep when somebody keys up on a repeater. And that, again, receives a signal, boosts it, retransmits it. Digital equipment. Digital is really the way that we've gone. Digital radio equipment allows a lot more than just voice to be used. We can use a lot of mobile data where we're receiving calls on a computer at the same time as we're talking on a radio. We may also be transmitting an EKG over this. And then cellular phones or mobile phones get used a lot in EMS. It's a little bit more protected. People, that patient information isn't as freely transmitted into the cyberspace or into the the airwaves where everybody can listen. So We do use a lot of cellular phones these days, although remember that they are limited. There's not 100% coverage around the nation. So this table shows us a few guidelines for radio communication. Make sure it's on, make sure you're on the right frequency. A lot of this is kind of no-brainer stuff, but it's worth mentioning at least, because occasionally we scream and scream and scream and holler and holler and holler, and we get nothing. And if we stop for a moment and look and say, "Ah, crap, that was our fault. Dang it." So listen before transmitting. Avoid interrupting other transmissions. This is terrible, particularly in people that are new into the career or the profession. Is they don't take a second to listen. They just hop on. They get their adrenaline gets the best of them, and they're screaming crap over the radio. Press your PTT button and wait about 1 second to avoid cutting off the first part of your transmission. It is not instantaneous. It's close, but it is not instantaneous for when you are transmitting. So hold the microphone 2 to 3 inches away from your mouth and speak clearly in a normal volume, normal tone, and control your voice inflection. Aim for kind of a neutral and professional tone. You may be excited, you may be nervous. Try to keep that out of your radio transmission. It helps to convey that professional image. Holding the microphone 2 to 3 inches away from your mouth is huge. Otherwise, it sounds like you're talking through a wrapping paper tube. You get the big echoey tone, and it's harder to understand. I'm not going to read this next one to you because a lot of that depends off of local protocol, which way you're going to actually make your transmissions. Wait for somebody to say go ahead, and then if they tell you to stand by, I mean, just hold on a minute. Remember, particularly if we're talking things like communication centers and dispatch centers, they may be listening to 10 different frequencies. They may have 35 departments they're listening for. So you're not the only one. And if you have emergency traffic, you can state that, and usually they'll get you some priority. Attempt to transmit for no more than 30 seconds without a pause. If you're giving a radio report to a hospital, that means keep your radio report short, sweet, and to the point. Nobody cares that patient is wearing a beautiful blue down-filled parka with a fur-lined hood. Nobody cares about that crap. In all honesty, here's what the nurses want to know, or whoever's receiving your radio report. They want to know who you are, what you have, how stable they are, and how soon you're going to be there. That's really what they want to know. The extra stuff is all nice to know stuff. So if you've got vital signs for them, yes, that's great. If you can tell them what treatments you've done, yes, that's great. If you can tell them the highlights of why you believe this patient has this medical condition, that's fine. But keep it short, sweet, and to the point. Be concise and organized. So you and your partner dispatch to the home of a person with a reported person down. When you arrive on scene, you find 2 people in the home are ill. So this should kind of give you an instant heads up. 2 people are sick. Upon your assessment, you determine that both individuals are going to require transport. And at what points during the call do you communicate by radio or cellular phone? Well, I think that's pretty obvious. I mean, you're going to obviously need to communicate to dispatch that you need possibly a second truck. You're going to need to communicate to the emergency room. You have 2 patients coming in. Give them the reports on both patients if you decide to transport them in one truck. And of course, communicating with dispatch. If you're having a second unit respond, then you're going to have to communicate back and forth with them. So there's several transactions that are going to have to happen here. Remember that cultural differences and language barriers can present certain communication challenges. A lot of times we do end up having to use an interpreter. Sometimes it's less than desirable conditions that we have to do this as well. So we may have to, once in a while, rely on kids. Remember, a lot of times when the kids are in the system, they're learning English in the schools, and they speak the other native language at home, so they often are able to communicate. It's not ideal, it's not the best, but sometimes it's all we've got. So therapeutic communication, or talking with our patients. So be aware of that cultural diversity. So some people have a very specific expectation when they're being communicated. So things such as Mr. and Mrs. That's always a good approach, is to start with Mr. or Ms. And their last name. And many times the patient will ask us to call them by their first name, but don't automatically assume. I mean, that's a sign of respect that we use a title of respect of Mr. or Mrs. or Doctor or Ms. or what have you. So keep that in mind. Differences in perception. The differences in the way that we look at things, maybe today, and I'd venture to guess that there's varying opinions on this. There's perhaps people in our class that have a very wide open view of, say, body art. They see it as it's art. It's not a big deal. But remember that the majority of the people that we work with and deal with in EMS are elderly. And the elderly, in most cases, believe that bikers and sailors had tattoos, so they were kind of ruffians, as opposed to professionals didn't have tattoos. Whether you like that or not, and depending on which road you go down, you still have to look at what is kind of the norm and the standard for where I am working, where I am performing my skills. We have to be on the conservative side in many cases, like it or not. And people are like, well, it's my right to be an individual. And you're right, it is your right to be an individual. However, those rights sometimes, that right to be an individual sometimes gets put on hold when you go and enter a certain profession. So I'll stick a plug in here. Be careful. Think before you ink. Because in many cases, many departments still require you to cover all tattoos. Examine any biases or stereotypes that may exist there. We're still going to run into those things. There's many times in which there are stereotypes, there are biases. That, a couple of white boys are responding to a black part of town. A couple of white boys in a truck with lights and sirens on it, wearing uniforms. That could be very quickly misconstrued. So we have to understand that those things still exist in many cases. Language barriers, of course, huge, big problem with these language barriers. But there are things out there. They're coming up with better and better apps that do translation for us. There are phone services we can call in and use and take advantage of. Of course, our first impressions, what our first impression gives us may not be a true picture. What the patient's first impression is of you may also not be a true picture. And just remember, convey respect and empathy. So try to be on your patient's side. What is in their best interest? We need to try to provide the patient some privacy. So everybody that shows up on this call, the 4 guys that came in off the pumper, the 3 police officers that also showed up, the first responders that showed up, the 2 or 3 people that showed up on the ambulance, 19 family members, a couple of neighbors, the press. All these people don't need to be present. It is okay to kick people out. Keep a person or 2 around that can give you some reliable portions of the history, or maybe it's even more appropriate to remove some people and have other people interview those people separately. We'll take, for example, you ask a 15-year-old girl, are you being sexually active? The parents are standing over the top of her. I'm almost guessing you that the answer is going to be no, regardless if she is or not. Whereas if you remove those parents and the guardians and everybody else who could potentially hear this embarrassing information, you may get the fact that, yes, she is sexually active. And you may go and ask the parents. The parents may know that she's sexually active, or they may not. Control the noise. Again, I mentioned that that occasionally, or most of the time actually when I walk in, because I have actually a couple of hearing deficits. Number one, I have tinnitus, which is a constant ringing in my left ear, and second, I have high-pitched hearing loss, in which makes it more difficult for me to pick up some of the specific inflections. So I will turn off as much background crap noise as I can. Nonverbal communication. How are you appearing to your patient? Is your posture? How's your gestures? Do you have your arms folded in front of you? Also remember there's personal space considerations. So there are things like how close should I be to a person versus how far away. Most people are fairly comfortable with you being within about the 3 to 6 foot radius from them. And in some cases, obviously, you're going to have to get a little closer. But creating some space between you can help them be a little more at ease. And touch can be a very sensitive issue. So I've had people who've gotten very upset. You place a hand on their shoulder and said, try to be reassuring. I've had people actually come back and say, don't touch me, and get very owly on it. So sometimes it's best to be more reserved until you can get a better sense of how the situation is going. Additionally, in verbal communication, we have things such as active listening, being available, open-ended questions where we don't give them a range of options. We make them come up with their answers. Closed-ended questions where it's yes or no, true or false, red, white, or blue. And then leading questions. Leading questions are not a good idea in most cases because they suggest the answer to the patient. We're looking for a specific answer. We don't want them to give us the specific answer. We really want them to give us the answer that meets the question. So we've talked about a number of good active listening techniques, things such as making yourself available, telling them, I need to sit behind you for a couple minutes to talk to the hospital, let them know how you're doing. Other things like, if anything changes, anything comes back, please let me know. Asking questions such as, can you explain this or describe this to me? Tell me what you were doing when this happened. Not were you resting or were you working? Were you sitting up? Were you laying down? Tell them, ask them, give them the opportunity to explain it. Occasionally, we do need to kind of wrangle them into a specific set of questions or answers. We may ask about past medical history, and we may get from this 94-year-old lady everything that's happened to her since 1920. So it's really something that we have to occasionally change our techniques in order to, for the sake of time and efficiency, get where we need to go. Check your understanding, clarify the information, and avoid confrontation. So things such as asking, okay, so I understand that you have a history of such and such, and you're concerned that you're having a stroke. You're concerned that this is a new lesion or new wound. You're concerned that you've never had seizures that lasted this long. So it helps to let the patient know, hey, they are really paying attention. Clarifying. So if you don't quite understand it, ask them in a different way. Ask them, I'm not quite sure what you're saying here. Can you explain it in a little different way? Confrontation. Point out the inconsistencies in a patient's communication. That actually can create a big wall. So try not to disagree or try to argue with them, because when they close the wall, it's so hard to get that wall back down for you to get better information. So facilitating. So if a patient has a difficult time getting past certain question or certain part of the conversation, we start to ask them, maybe ask them a different question or ask them something in a different manner and go on. So we just move forward. because we can't stall in many cases. If it's an important piece of information, we can come back to it. Reflection. So you said this is the worst pain I've ever had. I took 5 aspirin this morning. And you say, so you took 5 aspirin this morning. Of course, that's something that helps us confirm what they've said. And perhaps it's something that we're doing on purpose. We repeat it back so one of our partners hears it and maybe makes note of it, or that's a key or a clue for somebody else to do something. Silence can be very awkward. I think a lot of people get very nervous when there's an extended silence. Make sure though that you give enough silence in order to allow the patient to formulate what they need to say. Remember, if you are formulating an answer before the patient's done talking, you are not fully listening to them. So that silence is actually an opportunity to come up with a complete and correct answer. And then you can also summarize, where you kind of bring together the main points of the conversation and say, here's what I'm heard you say. So we have a couple of pitfalls: multitasking and dividing your attention. This is not a good idea if you can avoid it. In most cases, when I respond to a call, I am looking at doing the history, doing the talking, whereas I'm hoping that my partners are taking care of the physical, hands-on, vital signs, so on and so forth. Now, occasionally, it is it's a serious nature call, so you have to do a few things like spike an IV bag or get ready to stick an IV and ask some more questions. It depends on the resources we have available. If you can avoid multitasking, do so. Request an explanation, which implies blame or disapproval. So how did this happen, or why did that happen? If you can find better ways to ask the question, do so. Because if you're trying to pigeonhole them, or you're trying to basically condescend them, that would be another roadblock to communication. So overloading the patient with information or questions, one at a time by one person. One person asks questions. If other people want to know information, they should ask the person who's doing the question, because that all comes through the same medium. So that same person is asking and getting the answers. If you ask the patient 3 or 4 questions at the same time, do you have chest pain, shortness of breath, nausea, vomiting, night sweats, diarrhea, so on and so forth, they may lose track of how many questions you just actually asked them, and they may just give you a blank, oh yes, I have that. Well, what do you have? Giving advice or opinions, in most cases we should really try to avoid doing that, because advice is not always good advice, and sometimes advice leads us down a slippery slope. Gets people into trouble. Changing the subject or interrupting. Occasionally we have to do this. If we can avoid doing it, that's the best. Changing the subject is rude. Interrupting somebody is rude. So trying to get the patient to steer the patient in the right direction sometimes is what we have to do. We may have to do a clarifying question. Oh, I heard you say this. Can you tell me more about that? Might be something we can use, because it sounds like, well, we really are listening, we're trying to clarify, but we're really trying to get them to move on. False reassurances. We do not tell people it will be okay. Telling people, oh, it'll be okay, can diminish your trustworthiness. And do not use things like, oh, I know exactly how you feel. You don't. You're not them. You don't know. Don't say it. So you can say, I had a similar situation. That must be very difficult for you. I was in a similar situation. But not, I know exactly how you feel, or everything will be okay, because we don't know either of those. Occasionally we'll run into some odd scenarios in which communicating with patients becomes difficult. Age-related can be issues. Sensory deficit. We can also have cognitive impairment. The patient, a very small child, is not going to be able to give us full answers to everything that we are asking. Maybe we have an elderly patient who's not responding to our questions. Well, did we bother to check to the patient use a hearing aid? Is the hearing aid on? Teeth. Does the patient have their teeth in? they don't have their teeth in, then perhaps they're not going to talk much. So, and then try communicating initially with them, even if they're unresponsive. Maybe you get something. And then if not, you kind of migrate on to the next person. Do not assume that the patient cannot communicate. Remember, a lot of times the patient actually can hear you. They just may not be able to fully, and understand you for that matter, they just may not be able to fully communicate back with you. They may not be able to fully form a sentence or even the words that they need to. Verify additional information from family, caregivers, bystanders, so on and so forth. And don't forget about those assistive devices, the hearing aids, the dentures, the eyeglasses. A lot of times things get left behind because we're kind of in a hurry, but is that really in the best interest of the patient? You know, that patient has to eat sometime. That patient, you know, how would you feel if you couldn't see, couldn't hear, and couldn't eat? It's a big problem. If the patient has eyeglasses, even if they're unresponsive, put the eyeglasses on their face. That's the safest spot for them. Chances are pretty good we're not going to bash them in the face with anything. Otherwise, they get left behind, they get sat on, they get dropped. You know, those sorts of things. If you can put them on, put them in, do so. There's another video on effective communication. You can go to that link. Try to involve the family members in communication because using additional positive influences can often help us get more information out of a patient. There are certainly those times, though, it will be a roadblock. So the parent of the sexually active teenager will be huge. So don't let the family members answer for the patient who can answer for themselves. You may verify some of that information. You may, you know, pull them off to the side and ask for, you know, does that sound right? Does that, you know, what does, from what you know, how does that match up with it? But if the patient can answer, let the patient answer. And a lot of times family members are anxious to give you answers. And if they're the ones that are constantly spouting out the answers, a good response to them may be, I'm really kind of assessing how with it your loved one is. I'm watching to see how they answer these questions, and then we'll make sure that we get the other side from you. But seeing how the patient answers the questions gives us a lot of good information. You can tell them stuff like that because it's not untrue. It's absolutely true. We are looking to see how well the patient's answering questions. But in reality, we really want to get the patient's perspective. All right, make sure and protect your own safety when dealing with hostile patients. Try to stay calm, try to stay professional, but remain ultimately alert and ready to get the heck out of there. And for many reasons, the patient may be uncommunicative. Maybe they're scared of the situation. Maybe they just are embarrassed. Maybe they just don't know what to say. Or maybe they are completely unresponsive. They're just not able to give you any info. All right, so consider time that you were uncomfortable sharing information with a healthcare provider. Why were you uncomfortable? Was it something you felt was taboo? Maybe it was a problem sexually, or maybe it was a psychological issue, and you felt it was kind of taboo and didn't want to discuss it. What was it about the healthcare provider that made you reluctant to share that information? So maybe you're a female that goes to a male doctor, and you were a little ashamed to talk about a certain female issue that you were having, or it could be the other way around. And then how do you avoid creating similar patterns for your patients? So is there another same-sex provider that could go in there and talk to that patient? Obviously, they need to be appropriately licensed to do so, but that helps the situation. Maybe it was you just had family present with you and you didn't want to talk about it. So we'll shift gears now to documentation. We're just about done with this chapter. The patient care report, it documents the patient care, whether that's electronic or paper. It provides a number of points of important information. Number one, continuity of care. Probably foremost is we want to make sure that the patient gets continued care for their current condition or issue. Secondly, information for billing, for insurance claims, for statistical information. We are trying to paint a picture so the bill gets paid appropriately and the patient suffers the littlest out-of-pocket expense possible. Also statistical. Each state requires, almost all of the states require their EMS services to report certain data, and this helps drive the EMS practice. So if we're seeing a large number of patients are suffering negative consequences from a certain type of treatment, gathering that data, submitting that data into the various clearinghouses of data will help drive future changes in medical care. It is a legal document. Of course, maybe your only backup as you get called into court to defend your actions or as a witness. And then also we get that data for research and educational purposes. A lot of times we're doing quality assurance off of the patient's run records. And so if we're watching maybe a new paramedic, or each paramedic undergoes a review every once in a while, they may select a handful of run reports to kind of do a spot check on and say, oh yeah, well, it looks like everything you're doing is appropriate. Medical directors are responsible for doing a lot of that review stuff. So with documentation, we have standardized data collection. There are types of patients who seek EMS, there's types of care provided, and the outcomes of the patient. And a lot of this information also gets funneled into NEMSIS, National EMS Information System, and a lot of that information is compiled, and it's in a big database in which people can draw certain blind data from. It's not going to have patient identifying information. It may have things like age, sex, and race, but other than that, it doesn't give specifics. But you can look at these things. You can look at times of treatment, you can look at different types of treatment, complaints, and so on and so forth. Okay, so we have a number of sections of our patient care report. Everybody's report's a little different. Everything is set up a little differently. We're seeing maybe a little bit more standardization with certain state-required reports and or certain vendors. There's a couple of electronic patient care report vendors out there, and things look pretty close to the same. So we have administrative information such as our times, what unit went, the crew that responded, things of the patient demographic data, so the patient's name, their address, their sex, their date of birth, their age, ethnicity, so on and so forth. Things such as their assessment information, such as the vital signs and any other signs or symptoms that were detected. Maybe it's things like Glasgow Coma Scale, lung sounds. We may have things such as the narrative portion. The narrative portion of the call in many cases is really the most important part of the call because that's the part that paints the picture. So depending on the way you write your narratives, that's what's going to paint the picture that you're going to get to come back to eventually. Any treatment that was provided. So if you gave them oxygen, if you started an IV, or you gave them a drug, that has to be documented. So there's a number of narrative formats that people will use. There are definitely advantages and disadvantages to each of these. This one is an example of the SOAP format. I am not a fan personally, but I know many people who really do like the SOAP format. So I think the SOAP format leaves a lot to the imagination, and that's why I don't care for it. So the SOAP format, SOAP stands for Subjective, Objective, Assessment, and Plan. So subjective is information about the problem as given by the patient or the subject. Objective are things that we were able to observe, so things that we gathered, what's not specifically told to us from the patient. It's things that we acquired during the assessment. The assessment is actually your field impression, and that's one of the big things I don't like about this is assessment. People are driven to believe that's where you document your assessment, but it's actually your field impression. Most of your assessment actually occurred in the S and the O. And then your plan. What did we do? How did we treat them? And then how did we transport them? So that's the SOAP method. And I do know that there are a lot of people who are fans of the SOAP method. There are other methods out there. If you look in your textbook, just on like page 126, they show you the chart method and the cheated method. Cheated is a variation on chart, but chart stands for chief complaint, usually start with an introductory statement. Okay. Chief complaint, history, assessment, treatment, which is RX, and transport. Modified, so basically cheated is chief complaint, history, exam, assessment, treatment, evaluation, and then disposition. There's all kinds of variations. The probably most common type of narrative that gets used, though, is a chronological narrative, and that's the way that I generally will write mine. I start out with actually a modified section, or actually not, I should say start out, but part of my my narrative has to do with looking at very specific signs, symptoms, and assessment data, so I make sure that I get it every time. But then there's also the narrative portion of it that is chronological. So we start to go from, we were called for this, when we arrived we found this, we did this, we assessed this, we did this treatment, we moved into the cot, we reassessed this, we started transport, on the way we did this additional treatment, found this additional assessment item, we got him to the hospital, we gave him a report, we turned over care, and that's kind of just, you're just walking your way. It's almost like you write the transcript if you watch the video of what happened on the call. So a reminder for written PCRs, the correct way to correct an error is to one line through it. Do not scribble it out. It looks like you're trying to cover something up. So one line through it, initial it. It's also a good idea to date and time that. So when we do them on the PCR, after we've made the initial submission of that PCR, if we have to go back and do a correction on it, the way that that gets corrected is it puts a timestamp usually. Most of the ePCR things will say this was added at this date and this time by such and such person. So it's tracked. It is tracked in there. Legal considerations. The PCR is a legal medical record. It's protected by HIPAA. You can't just distribute this to anybody. It needs to be kept secure. It needs to be, and anybody who needs access to it has to have either the appropriate documentation to get to it. Talks about that. Special documentation circumstances. If you have to return to service before completing a PCR, and this happens a lot of times that we're in a busy system. We may be running, and we have to go back in service. Keep any notes that you have, and try to get into your PCR any critical information prior to responding to the next call. And if you have to go back and fill stuff in later, fill in the blanks later, then you obviously rely on your notes. Multiple casualty incidents. In most cases, we don't do a full PCR on everybody that is a multiple casualty incident. We may have a modified form. We may have a modified computer document. Or we may be relying a lot on those triage tags to use as a document. Refusals of care. I've mentioned this before in medical legal. This is really something we have to hang tons and tons of paper on. A refusal almost has a bigger narrative and it's almost a bigger job to chart than a patient we actually transported, because that's the #1 time in which people come back and make legal actions. And then documentation outside the scope of the PCR. Not everything goes in the PCR. So if something happened and we blew a tire on the way to the call, we may document in there that due to a mechanical issue that we were delayed, or maybe it's something that your service chooses not to document in there. And there may be a separate report that has to be done, an incident report. Maybe we have to do some documentation on a suspected abuse or an assault. Those sorts of things are beyond the scope of the PCR. Those are going to be specific to each agency or service. All right, so thinking about it, you and your partner are beginning the primary assessment of an elderly man whose daughter called 911. The man is agitated and he refuses care, and your attempts to convince him are not successful. How do you document his refusal of care? Very, very carefully. You have to hang a lot of paper on this. You have to try to involve his daughter, get his daughter involved in trying to convince him. Because if he's very agitated, it's possible that he could have something like hypoxia or hypoglycemia. And if this happens and this patient refuses and something happens to them, we're going to be held liable. It's not going to end up a good thing.
So you've got to involve the family member. You have to exhaust all efforts and then document each one of those efforts fully and completely. Effective communication, and to summarize, effective communication is essential to every aspect of our job. To be aware of our verbal and nonverbal communication. So if we have specific character traits, specific things that we do, we need to be aware of those. One of mine is I'm really bad at crossing my arms in front of me, mainly because I think, well, where am I supposed to put them? But come to find out, well, not come to find out, but it's well-known fact that when people look at people with crossed arms, they believe, oh, well, they're standoffish. They're not listening. And in fact, that's not the case in most cases for me. It's just simply I don't have anywhere else to put them. Strive to improve your communication and teamwork. It's critical. If you can take teamwork and leadership classes, do so. Establish a rapport with your patients and use the various therapeutic communication techniques to clarify the story. Be proficient in the use of EMS communication equipment, know how to use it, and adhere to the guidelines. So things like do not curse over the radio, no profanity, no patient names over the radio. You can do this over a cell phone, but not over the radio. Breakdowns in communication will jeopardize your safety and your patient's safety.